time dependent. It is time dependent. You may not always have the chance to summarize, but you can briefly summarize if you manage your time well. And if you find that you're actually running out of time and that you can't summarize, then perhaps it's best to keep updating your patient and signpost so that they already know what was going on and you don't need to summarize. Other areas that you may summarize briefly is explaining the findings. Again, that is a summary. And in the history, again, that is a summary. So when you're giving the provisional diagnosis, Joyce, for example, a suggestion would be to explain to them, from everything that you told me, you mentioned that you've been having, chest pain that keeps coming and going, and that it's usually triggered by movement, such as going up the hill. And I've examined you today as well, and you've already explained the examinations, by the way. Unfortunately, I suspect the most likely cause of your symptoms is what we call a stable angina. This is when there is reduced blood flow to your heart. And so when your heart needs to do things and it needs more flow to different parts of your body, there is reduced blood flow, which causes pain. At the moment, it's stable because it's only the same amount of strenuous activity that causes your pain. And there are things that we can do about that. And you continue to define and start managing. If there are any investigations that need to confirm the diagnosis, think to yourself, a chest infection, I need to confirm by doing an X-ray. Think to yourself, hypothyroidism, we need to confirm by doing thyroid function tests. Different types of investigations that will confirm the diagnosis. If somebody has a DVT suspicion, I suspect you could have, a deep venous thrombosis, and you define the deep venous thrombosis. This is when a clot forms in the legs, the veins in the legs, and it causes pain. Now, it can travel. And so it's important that we do something about it. Mainly, we would thin out your blood by giving you blood thinners. But I do need to send you for some investigations to confirm this. You do need an ultrasound scan, a gel scan of your legs, and what's known as a D-dimer test as well. In the meantime, I'll start you on some medication if you don't mind. These blood thinners will help against the clots. Is that all right? Do you have any questions? Is everything clear so far? And so they probably need to be sent over for investigations. And if you're in the GP, that investigation is usually done at the hospital. They usually need to be offered, an ultrasound gel scan. And if that's not available immediately, then it should definitely be done within 48 hours. But these are not things you need to mention to your patient, because these are things that are already in place by the time you refer them to the hospital, and that you're starting them because there's going to be a delay in the investigations. You would start them on the blood thinners according to the guidelines. In any case, pulmonary embolism is the same. It's confirmed with a CTPA. And if it's confirmed with a CTPA, what I need to tell the patient is that they have a pulmonary embolism. This is when a clot travels most commonly from the legs to your lungs, and it really causes these severe symptoms. Unfortunately, a clot that has traveled to the lungs can be life-threatening. It's important we move quickly. I would like to arrange an admission for you. Do you think that would be okay? Oh, doctor, I can't. I've got kids at home. If you didn't suggest, they would not be able to give you the things that they are supposed to give you, any concerns, and you need to listen and you need to hear. And so from day after day, we look at these problems and we learn how to deal with them, and we become perfect. Remember that practice makes perfect. I'd like to quickly walk through common managements that you might find yourself doing. Again, the baseline routine investigations you might do. You just need to explain, I'd like to do a few routine investigations, and then you need to mention the key areas of these routine investigations that are specific to the situation. So I'd like to do a routine blood test, check your blood levels, your kidney function, your liver function as well. I'd like to check your sugar levels, and I'd also like to look for any markers of inflammation in your blood, and check your clotting if that's relevant as well. Good. The treatment, you need to usually explain the treatment. And if it's confirmation awaiting, then you need to explain how the treatment will occur if it is confirmed. So I'd like to do your thyroid function tests. And if it confirms that you do have high thyroid levels, we will make a referral for you to the specialist who will start you on a medication known as carbimazole. This medication will reduce the amount of thyroid in your bloodstream. They may also suggest other types of treatments if that fails. This could include a radioiodine drink that can destroy some of these cells that are overproducing thyroid hormones. And sometimes they may suggest a surgery to reduce the size of the thyroid or completely remove it and put you on medication for your thyroid. But again, I don't want to worry you too much. We will make sure that we explain everything to you again. Is there any questions so far? You also mentioned that you are really struggling with the symptoms and that you've got these tremors and the sweating and it's affecting your life. Until you see the specialist and until the results come back, we can start you on some medication to help with the symptoms. What do you think about that? Beta blockers. Okay, so the side effect could be some clammy hands. It could be feeling cold. If you do develop any of these symptoms, please come back. Admission. Some situations require admission. You need to admit the patient. PE was the good example. You need to arrange an admission for the patient and you need to explain the steps and you need to take your time. For discharge, again, some patients, they came to the emergency department with an asthma attack. Today, you're here after attack to explain how they could do their PEFR for the future and explain some of the discharge medication that they should take the prednisolone and that they should take it for the next 3 days and obviously other things and discharge them home based on a successful PEFR. So the examination in the situation is for them to do the PEFR. When you get the value, you need to compare it to the PEFR chart, and the expected value must be more than 75% for the person's age and the person's height. Referring to a specialist, hypothyroidism and other situations, you may need to refer. You should know different referral timelines, and I'm going to go through those in a second as well. For your follow-ups, usually a follow-up, say for depression, will be 1 week or 2 weeks, depending on the age, and obviously high risk, low risk. For the leaflets, this is to give patients more information. Now, at the end of a discussion, we give them leaflets. If something has ever reached a stage where you needed to do more than an X-ray, again, PE, DVT, you may need to involve your seniors. For simple chest infections and such, you can take a second opinion from your seniors as well. Always involving your seniors is okay. But if you make the mistake of thinking that takes away the responsibility from you to explain things to your patient, then that would be wrong. But you can always involve your seniors, safety netting, and warning signs, when to come back, when to call 999. Expectations. Is there anything else you were hoping we could do for you today? Is at the end, and sometimes it can also be with your usual ice. If somebody is clearly depressed today and I want to ask them about the trigger, I will ask them ideas after my initial history. I'll say, what do you think is causing you to feel low at the moment? And what's worrying you the most about how you're feeling? And I know that you came today looking for help. I just wanted to make sure we can help you properly and exactly how you need. Is there anything specific you were hoping we could do for you about the way you've been feeling recently? And so learn how to take control and learn how to also use your ice in different ways. And we will do that together. So I mentioned a lot about ice. I talked a lot about effects, and I talked a lot about the biopsychosocial model of disease and acknowledging concerns. For acknowledging concerns, there's one important thing I need you to know. We acknowledge the concerns as soon as they are asked. So these are worries that come out. Is it something serious, doctor? Is it cancer, doctor? Well, look, I could see that you're worried about cancer. And I want you to know cancer is one of the conditions that we are always on the lookout for. I just wanted to know, is there any particular reason why you're worried about cancer? Well, my friend, he had back pain just like me and he got cancer. Doctor, do you think it's a tumor? Well, headaches can be caused by many things. And one of the causes of headaches are tumors. That is right. However, I was just wondering, is there any particular reason why you're worried about tumor? My uncle, my auntie had a similar headache and it was a tumor. Right, okay. Well, I'd like to continue asking you some questions and assess you, and then I can address that for you as well. Is that okay? Yes, that's okay. So then when I do my assessment, I'll explain to them. So from what you've told me, your headache is a headache that comes and goes, and that seems to have triggers. And one of the triggers that you mentioned today could be the stress as well that you're going through. A tumor would cause the type of headache that is constant, doesn't go away, and also is worse in the mornings. So I'm not worried about a tumor right now for you. And you won't be needing a CT scan because it would just put you through unnecessary radiation. And it's very, very unlikely you don't have a tumor at the moment. So I want you to relax a little bit. And you also smile when you're speaking to your patient. So this takes practice as well, yes. But again, every single day, you do your scenarios, you do them with your practice partner, you do them with the tutor. If you're part of UKPass Academy's full course, we have already designed supervised practice sessions. We have designed multiple ways that we can continue to make sure that you are ticking all the boxes that you need. ICE, ideas, concerns, and expectations, is about being patient-centered and asking ICE generally after history and before the examinations. Is there anything concerning you about your symptoms? Do you have any questions or worries so far about how you're feeling? And are there any specific things that you were hoping we could do for you about what you're going through today? So that is fantastic. The NHS system. I hope you guys are having fun. I know I am. I enjoy doing this, and it's very nice to see you guys join us. The NHS system is very simple. It's primary, secondary, and there's a third kind called tertiary, but tertiary is highly specialized hospitals like cardiac transplant hospitals, and we don't really need to discuss that. What we do need to discuss is the primary and the secondary. If something is outside of the hospital, it is primary. It's that simple. The gum clinic is primary. A pharmacy as well is primary. So if a pharmacy is primary, you can tell what's going to be primary. Everything outside the hospital, including the GP. Secondary is everything in hospital. So the respiratory department, the emergency department, the surgical department, the acute medical department, this is secondary. For you, you should know what this means in your scenarios. If I am in the GP, mainly, I need to recognize things that require referral, and I need to be able to treat simple conditions at the GP. If I'm in the hospital, I should know that this means I can get results of investigations faster, and usually I do need to explain things instead of sending to the hospital. Mostly it's going to be definitive management, treatment, surgical, and things like that. And your seniors may need to come and review at times as well. So the referral timelines I'll go through, but before that, GP surgeries. They are located outside the hospital. They are for minor or chronic illnesses, and patients make an appointment to see the doctor. The GPs can perform every single investigation. They just need to wait for the results. They wait longer than in the hospital, but they can request urgent investigations within 48 hours, for example. 2 to 3 days is what it usually takes for routine blood tests to come back, maybe up to a week or more. And so for the purposes of your exam, just know that if you do any investigations, you make a follow-up in 1 week's time to discuss the results. In the UK, X-rays can take up to 10 days, and they're not testing this precise knowledge. They just want you to make an appointment to discuss the results. GPs will make appointments in a week's time. For referrals, I want you to know a couple of things. If you're in the GP, you have to have good knowledge of your referral timelines. There's going to be a separate day where we discuss the cancer service, which is a 2-week urgent referral. And you need to say some things for this as well. And I'm just going to give you an idea. Well, I will be referring you under the cancer service so that you can be seen urgently within 2 weeks. I want you to know that not everyone who is referred under the cancer service actually ends up having cancer. We just want to make sure we are safe. You can take someone with you to the appointment, and please, if you miss your appointment or you don't receive your appointment letter within 1 week, please come back so that we can look into it for you. So this is how you describe the cancer service urgent referral pathway. Other urgent referrals that are not the cancer service can also be 2 weeks. But again, the cancer service 2 weeks is one important one you must know is 2 weeks. Other urgent referrals can vary. A couple one to discuss with you is obstructive sleep apnea. If somebody has obstructive sleep apnea and they have an occupation as a driver, then they usually need to be referred urgently. This is 2 weeks, But the time frame the guidelines say, for example, is that they need to be referred, seen, diagnosed, and started on treatment within 4 weeks. So you don't have to memorize those kinds of things. You just need to say urgent. But if it's cancer and it's suspected cancer, they will need you to make sure you tell them that this is within 2 weeks and that, they can take someone with them to the appointment, and that not everybody who is referred under the cancer service ends up having cancer, and safety netting them for a missed appointment. Otherwise, I've got somebody with a pulmonary embolism. They have low oxygen levels. They have pain. You need to arrange an admission. But your job doesn't stop there. Until the ambulance arrives, we will continue to monitor you. We will give you some oxygen. We'll give you adequate pain relief. If the blood pressure was low, I would need to do what? Exactly, give fluids. And so there is pre-hospital management that you should be aware of. And if you're on the phone and somebody seems to be having a heart attack on the phone because you asked the Socrates and you found out that the pain is central, it's radiating, and it's been going on for more than 20 minutes, you will say, I am scared, I am worried at the moment. Say, I'm worried. I'm worried that the symptoms you're describing could be a heart attack. And so if you have do you have any aspirin available at home? If you do, please take 4 tablets, 75 milligrams each tablet. Take 4 75 milligram tablets immediately, and we will arrange for an ambulance to come right now. Stay on the line. I just want to ask you more questions until the ambulance arrives. This is over the phone, recognizing an acute situation. If it was pulmonary embolism, same thing. You would arrange for an ambulance to come to them. You're worried it could be a pulmonary embolism. Know what to do. Anyway, if you're not arranging an admission, then you would be arranging for an emergency or an immediate referral. A patient with lower back pain from ankylosing spondylitis may need to be seen within 24 hours at the ophthalmologist center for an assessment because they could be having anterior uveitis. So you just need to know these different criteria. Same, if a patient has a retinal tear on an ophthalmoscopy, they need to be seen same day within 24 hours. Emergency means now, immediate means within 24 hours. You don't need to say anything other than the time frame. You do need to go now within 24 hours. We want you to be seen. I'm worried that you could have had a retinal detachment. This is when part of the retina comes away from its layer at the back of the eye, and it can be vision threatening, and assessment is very important at this moment in time. Good. Very urgent is within 1 to 3 days. That's rheumatoid arthritis, for example. And routine, non-urgent referrals to the specialist will be up to a maximum of 18 weeks waiting time, and they will get their appointment within 28 days. So those are the referrals.